Welcome, my dear students, to glide the slides, the second class of the C section. I would like you people to kindly keep in rapid touch with it and do not miss or skip or fast forward. This is a lesion in a 48-year-old villager presenting with abdominal pain. The history is quite vague, but then in a slide like this, it is too diagnostic. I am finding something like a huge ductular structure, and then there is obviously a lesion. Do you want me to call it as inflammatory? No. Congenital? No. What else can it be? And at this magnification, I would like to appreciate the branching and the rebranching appearance of this, which is better brought out over here. And if you people are not very clear about it, go to the history of conjugated hyperbilirubinemia. Please be very careful with these words, conjugated hyperbilirubinemia. So, what we are seeing over here is again a tumor. It is infiltrating the walls, and within the lumen, I am able to find a fine arboriform pattern over here. And there are some well demarcated glands also that can be seen. The wall is showing a reactive desmoplastic reaction along with probably some bacterial colonies and inflammatory infiltrate. I do not know what those are at this magnification. Coming back to our earlier friend, this was what that was seen. And this is called a sucker. This can help in the addition and the absorption of the nutrition. Like you and me, it has got a pharynx, it has got a ceca. There can be the ventral sucker also. And there is a uterus, there is a testis, in which case it happens to be a hermaphrodite. So obviously it is a parasite which has got the ovaries and the testis. So imagine the number of larvae or ova it can flood your system with. I hope you have made a diagnosis. Anyway, this is the normal bile duct epithelium. I find that it is lined by a columnar type of cells. And whenever there is a parasite, there can be a mechanical irritation, or there can be the antigen of the flukes, or there can be some chemicals which are produced by it. In which case, you find that there happens to be some abnormal proliferation. The body tries to resist it, and there can be some altered configuration or even the alteration in the cells. Adding fuel to the fire will be H. pylori, which can alter the microenvironment. There is a periductal inflammation and fibrosis. That is what we are seeing. I hope the pictures are very clear. And this is what the patient had been presenting with. Wiki dog, thanks to them. And it is a seeming superimposition that I have constructed. There is an organ, a normal parenchyma. This particular color you people should be able to identify, which is solid. It is not permeated with air. And there is another solid tumor, which is golden brownish white or brownish green. And it is infiltrating into the hepatic parenchyma. This is the structure of the tumor that we are seeing. Two things are very conspicuous in this. One, the tumor itself. I am finding it is haphazard in arrangement. So it is not a regular glandular tissue that I am seeing in all directions. Secondly, the cytoplasm is amphophilic and the nucleus is quite large, vesicular, and I'm able to see prominent nucleoli in many of the cells. So that is a good point. The third one can be the lumen. So it is a glandular type of a tube. Some areas there is abundant mucus secretion. Fantastic. So we have seen all these points. But what I have missed and you have seen or perhaps not seen will be the very, very prominent desmoplastic reaction. So it is the fibrocollagenous tissue that is there separating. So this will be one of the important points of diagnosis. So your diagnosis is written on the screen. It is a cholangiocarcinoma. This is again a fantastic picture. A slide like this, if it is given for us, it becomes debatable. And even we had some diagnostic problems because it was a biopsy, and then on this stage, I'm finding polygonal cells, which are large oxyphilic, eosinophilic cytoplasm, the hepatocyte. And on the right side, I am finding the glandular configuration of the tumor cells, which have been described earlier. So this is the case of a cholangiocarcinoma. Now, we should be aware of the patterns of hepatocellular carcinoma, which I will be taking in another class. What are the differences between hepatocellular and cholangiocarcinoma? Histology, a trabecular growth, glandular pattern. Trabecular means 4 or 5 cells broad. Bile production is common in this, whereas not in cholangiocarcinoma. It is more of a conducting system. Eosinophilic cytoplasm, rounded nuclei. Prominent nuclei, mucus production that I had mentioned over here. Hyaline bodies may be seen. Malarious hyaline, of course, the hepatocellular carcinoma is found. Abundant fibrous form. Please see this. So, contrast X-ray, these are the features. So, the diagnosis for us happens to be Clonarchus sinensis for the first slide and cholangiocarcinoma for the second one. Coming to the bile duct dilatation, it can be because of obstruction or without obstruction. In the case of obstruction, there can be a stricture, which again can be neoplastic, inflammatory, post-inflammatory. Neoplasms can be cholangiocarcinoma, gallbladder adenocarcinoma, pancreatic, and metastatic tumors. This is the culprit which will create problems. Inflammation can be pancreatitis, post-irradiation or chemotherapy, and any of the infections, biliary parasites, and primary sclerosing cholangitis, a question for us. Non-obstruction can be Carolus disease, choledochal cyst, recurrent pyogenic cholangitis, and primary sclerosing cholangitis. So this will be thanks to radiology assistant for the wonderful table that they have provided. We shall meet again. Thank you.